It's Amanda. Test, test, test. That's good. Maybe just a little hot.
Yeah, there you go. Perfect.
Test. Podium. Check. Check, check, test. 1, 2. All right.
you're going to have to forgive me for being a little bit nervous, but also if you can't hear me, just let me know, because I'm known to have a problem with my voice level. Welcome to our some of our new committee member also as well. And we have the quorum, so we're going to get started. First, I'm going to call the meeting to order, and I don't think we have any citizens registered for. We do not, so we're going to move on. I don't think we have the approval of the minutes. Do we have minutes to approve?
No, we do not. They were approved at the December meeting.
At the December meeting, okay. So we invite our CFO, Ms. Clark, for our CFO report.
Good morning. So we do have one request regarding a market assessment. So I would like to go ahead and move that into the closed session agenda item.
Yes.
That's all right with the chair,
That one.
later in the meeting.
Yes, ma'am.
Okay, thank you. All right, well, so I'm going to go ahead and start our financial report. This month is a little bit different because of the holidays. We've got 2 months worth of financials, both November and December. So rather than cover both of those in detail, I'm just going to focus on the December year-to-date, which ends our first quarter. Our year begins October 1, so it's not quite a calendar year. So we've got, like I said, 3 months completed. If anybody has any questions on November, I'll be happy to answer them at the end of the report. So looking at inpatient, our inpatient statistics continue to be lower. You'll see later in the report that outpatient is a little bit stronger than budget, but our admissions are down, as you can see. There are 2 boxes at the top right. The top one is month to date. The bottom one is year to date, and the red indicates unfavorable. The green is favorable, so it might not be higher or lower. Mr. Fisher requested that year-to-date box be there, and we've had it there for the last few months, but we haven't really talked about it. So hopefully that'll give you a quick visual of how we're doing. Our length of stay does continue to be high, along with the acuity of the patients as indicated by the case mix index at the bottom of the page. Year to date, we're about 9% higher than we budgeted. A lot of that, again, relates back to COVID positive patients. We do have quite a few in-house, and that tends to drive up the acuity. In our outpatient statistics, you can see the emergency department is about 7% under budget, but it is higher than it was last year. So we're seeing a slow return. Our urgent care is much stronger than last year and has been for the first quarter. And then on the right side of the page, you can see primary care as well as specialty clinic visits. Primary care is actually right on target for the year. It's about 0.1% lower, which is indicated by the yellow box. And we are running about 13% telehealth in primary care for the first 3 months. The specialty clinic visits, we did have a strong month in December, and our year-to-date is about 2% under budget. But we do have about 12%, very similar number in telehealth visits for those types. Some of the other stats that we look at, at the bottom of the page, we have both inpatient surgeries as well as outpatient surgeries. Inpatient surgeries remain to be below budget, but This month, they were a bit stronger and just under, about 5% under where we had anticipated them to be. And our outpatient surgeries, you can see a strong month for December, and year-to-date, we're still behind.
Hey, Sharon.
Yes, sir.
Is inpatient down due to staffing issues or emergency, or surgical suite shortages, or is it just due to demand?
It does have a lot to do with staffing, and we're also seeing a very high COVID positive test rate the day of surgery, and those are getting canceled at a pretty short notice, especially this month. I'm not sure how far back that goes to impact the full quarter. You bet.
I think there's a difference between staffing and open position. Is it staffing problem, or is it open position problem?
Well, I think some of the open positions are contributing to the staffing issues that we're having. We've also had some ORs as we've tried to update those. There'll be 1 or 2 ORs down, and those are now completely reopened.
I would say that it's multifactorial. There are increased number of open or vacancies that we have as the difficulty across the country and just being able to recruit new employees. Also, due with the high transmissibility of the Omicron variant, a number of our employees every day are turning positive, and it puts them out. So it does create some challenges for staffing. We have reached out to the state, both for our behavioral health units and for our inpatient units, to fill some of that gap. And so, as Sharon has said, the length of stay is a little bit higher because of acuity, so we don't turn those beds over as much. And the staffing makes it a challenge because the waiver does allow us to increase the number of care spaces. So it's just a number of things that are driving what we see.
Oh, I see. Thank you.
These 4 graphs really focus around behavioral health, which has remained very busy through the first quarter. You can see that almost every indicator is favorable from a volume standpoint. Year to date, we're about 7% higher on patient days at the top left. Clinic visits are about 14% higher for the first 3 months. And we see about 1/3 of behavioral health as telehealth visits. And our behavioral health emergency center is about 14% ahead of budget and higher than last year, same time. Some financial metrics that we go over. Our days cash on hand, you're going to start to see that kind of a nice jump both in December and January as we receive our property tax payments, just as a reminder. And then it'll slowly slope down as it has historically through October, November of last year. And then, we do receive most of the cash in December and January from those payments. Currently, we're at about 355 days cash on hand. Our net AR days have crept up a little bit. There are several reasons for that. As we prepared, I discussed a few of these with DT, but there's an industry over the last 6 months or so, insurance payments have slowed down somewhat. They are struggling with staffing as well. And there is an impact on this calculation. Our net revenue is actually declining faster than AR because it is at about a 90-day lag within AR. So some of that is just the denominator impact of the calculation, but we continue to watch that very closely. Our FTEs per adjusted patient day at the bottom right, you can see that that is about 5.8 FTEs per adjusted patient day compared to a budget of over 6. So our hours worked is favorable. And that's actually an hours paid calculation. So that's all pay, all worked. Our connection enrollment has dropped off a little bit in December. I would expect that we're going to see one more month of decline as the ACA programs ramped up, and that extension was through January 15th. Our patients go through an enrollment process. There are plans this year, depending on your income level, that were at no charge. So we did see some of our connection enrollment decline there in the traditional connection program. And then history will show that it will slowly ramp back up in the remaining months throughout the calendar year. Our payer mix is relatively the same. This is a year-to-date look. Medicaid is about 24%, Medicare is about 22%, and then we have our self-pay that's 16%, and our connection membership remains at about 18% of total charge. We do have commercial at about 14%, and a large part of that pie chart is really high deductible and ACA plans. So there's some not true commercial. A lot of them are based off the ACA. All right, so we have our income statement. Again, I'm going to focus on the right-hand side. Again, this is our 3 months ended December. We've got a couple of things going on actually with our year-to-date. As you can see in net patient service revenue, we're about 5.6 million short. The largest impact there is the CMS delay of the CHIRP and TIPS products. You're going to see a little bit of impact on a claim as well. That is paid per claim and would have shown in this net patient service revenue line. We also have a negative inpatient volume, as we discussed earlier, and that's offset a little bit with favorable outpatient volume in collections from that service. Our CMI remains up, so that has a favorable impact. But again, the biggest shortfall there is between volume and our CHIRP plan. They're still talking about that. We don't really have an update if that's going to be approved. When it is, then CMS will have to decide if that goes retroactive back to the first of the year. So there's a lot of discussions being had around that subject. Our retail pharmacies remain very strong. The largest impacts are in our specialty pharmacy as well as central fill, where a large volume goes through. That $4.2 million does have a lot of associated expenses with it below, but continues to be very strong. In our operating expenses, the second thing that's really creating some of that gap between our budget plan and the actual for the first quarter is our labor cost. We've already talked about a little, but we are trying to fill open positions. We're struggling with unfilled positions, as well as a lot of illness in December that impacted. So we are paying a lot of higher costs and incentives to work extra shifts, overtime pay, and that has driven salaries about $7 million over budget to date. We have had some savings in purchase service, however. Some of these are delayed projects. Some of them are lower claims with some of the lower volumes that we've seen. There's a portion of that that may be made up by the end of the year, and we are working to reproject this year to make sure that we understand how to get back on budget given some of these shortfalls. So at the end of the quarter, our net income is $22.4 million compared to a $26.8, about a $4 million gap. Are there any questions on the income statement?
I have a question. If we go back up to salary, what is part of that big salary expense part of our annual incentives and all of that we paid out?
That incentive, the one-time payment in December, was actually accrued until last year. So that is not impacting the numbers that we're looking at for '22.
Okay, so when you do the budget for your expenses in December, it wouldn't show up there, it would show up where?
So we accrue every month throughout the year for that payout that occurs in December, and that does show up in the salaries. What I thought you were asking is, was there an additional expense that hit for that payout in December?
Yeah, because we did increase it. That was my thought, that what we projected, what we were targeted, we increased that. So I was wondering if that wasn't part of our expense that we paid out in December that showed up in salaries.
But you actually accrued 100% of what we paid
I
out.
did, yes.
That was the deal. Remember, they accrued, because that was the discussion. We were worried about not paying out. Roger's motion was, if we don't use what we've accrued, then there's no reason not to, because we've got folks that have done a great job. So we accrued it all. We just weren't planning on paying it all until we had our discussion, and then we went and agreed to pay to it all, so it wouldn't have had an impact on the accrual. That's what I remember. Sharon.
Yeah, so the payout in December was all expensed to fiscal year '21.
Right.
Okay, all right.
Sharon,
Yeah, it's a delayed payment, I get that.
if we are over in salaries, but at the same time we have vacancies that is tough to fill, so the overtime and bonuses are greater than the vacant slots?
Yes, sir. So if you think about, we have vacancies. The only way to fill those is for current employees to work in that shift. So if I'm already scheduled to work 36 hours this week and I want to pick up an extra shift or two, then that extra shift is going to be at premium pay rates. So a lot of overtime expenses being incurred. We also have programs with patient care where we're trying to incentivize them to work extra shifts, so for scheduling. So we know that they're committed to work an extra shift a week for so many weeks.
So to your point, yes. It is really high dollar to pay out the additional incentive. In order to staff safely here, we did have to kind of dangle the carrot, and that resulted in higher incentive and sync pay, especially early on when we were incentivizing nurses who were coming in and caring for the COVID-positive patients. So all of that's not only here, but was on our inpatient floors, but also in our behavioral health units and also in our jail. So across the network, yeah, it was driving per pay period quite a few dollars. So it is to our advantage to get employees in and get them salaried and benefit full-time than it is to continue paying these kind of incentives or to use contract or agency to come in. So it's the per hour is just, I mean, it's just rising every day and trying to staff appropriately and safely.
Sharon, for the retail pharmacy, does that include PBM, specialty pharmacy and everything in there, or? I just trying to get the description for that.
So the retail pharmacy, we have about 8 or 10 different locations that roll up into that number. The largest is going to be the Central Fill JPS main pharmacy that's on the first floor of this building, and then the specialty pharmacy.
So it's in there. So
Yeah,
do-
there's some really high-cost drugs that go through the specialty pharmacy.
But do we benefit from the formulary and the rebate also as well when we have the retail pharmacy?
Yes, we do. Maxor manages that for us, and I receive emails of rebates that are coming through, sometimes weekly.
I see. Well, that's great.
Yes.
Thank you.
Okay, I'm going to move on to a claim. From a statistical standpoint, you can see that a claim had a strong month with their billed encounters. Month to date, they are pretty close to budget for the first quarter. Our claim provider graph, it's really hard to read on the screen, but this is on your board book itself if you want to study this. But it does show you the number of providers, so where's the largest piece of the pie? It's going to be in primary care, behavioral health, women's, and surgery. And then we have a lot of the specialties that are at the top right part of that pie chart. And then for the month, into December, again, I'm going to focus on the quarter again. A claim has been actually beating their budget for the main reason. You can see that a big pickup is in the salaries. We have had some open positions. We always have open positions that we're trying to fill in a claim. And so that has provided some benefit there. You can see the salaries and related expenses are about 2.7 million of that 3.5 million favorability to budget. Their net patient service revenue continues to be strong, and they closed the month with operating loss of 6.6 compared to a budget of 10.2. Again, 3.6 million ahead. So when you combine this all together at the on the right-hand side of the page, our consolidated operating income is 15.8 million compared to a budget of 16.1 million. So about a $300,000 gap into December. I will say that as we work through kind of a projection of where we're going to end up the year, given what we've learned in the first quarter, not all of the expense savings are going to be able to be carried through the end of the year. So like I just wanted to start to manage expectation with a claim. We don't expect to have 3.6 million of favorability for the remaining 3 quarters. We are filling those positions, and so that will start to get closer to budget performance. Are there any questions on the December year-to-date information?
Do we need to get approval for this?
Yeah, so I'll be asking for acceptance of the November and December unaudited financial statements.
I entertain a motion for approval.
Move approval of the acceptance of the reports.
Any second?
Second.
Second. Right. I guess we need to take a vote. Those in favor for approval? May I? In favor for approval?
Aye.
Opposed? Same sign. Motion passed. I'm going to move to item B. Consideration approval for the exemption to bid for the Fifth Amendment and the extension for the service agreement. with the DFW council, and that would be Ms. Clark.
Yes, I've got one contract today. The contract with the DFW Hospital Council, we use this organization for a lot of comparative reporting, the Texas State Agency reporting, and it's a unique set of services that we don't have access to through another vendor. So we are asking for exemption to bid and approval of this contract. It's about $115,000 annually. It is a 3-year contract for $344,000.
Move to approve.
Move approval. Shannon?
Second, I have a question.
Yes.
It's a membership, and the reason it's an exception to the bid is who else provides this service?
So you have to be a member of the DFW Hospital Council, and then we also have data submission that we send to them for that purpose.
Okay. And that makes it a need to be an exception. All I'm trying to figure out is why is it an exception? Because it sounds like we joined a membership, we get benefits from them, and that's just routine. So I was just trying to understand.
They're the only ones that can provide this information. So this is their data source that every hospital who is part of that membership submits to, and then we're able to pull that and use it for our daily kind of operation.
it.
So they're the only ones that can provide that, so that makes it an exemption.
All right.
Daphne?
I think they're the one that collect the THCIC data and
They
all that stuff. too.
really have quite a big
Okay,
database.
thank you.
Well, let me take the motion for approval with the exemption also as well.
Move approval of the exception to bid and for the Fifth Amendment and extension of the service agreement.
Second.
And, those in favor say aye. Oppose? Motion pass. Item C, Mr. Bender. Tony Bender?
I'll cover this one. Get to the page. All right, so Strata Decision is a really large
There
part.
he is.
Here.
We'll take a 10% discount for your ask.
Good morning, and I apologize, I was out of order there, sorry. So a little backdrop to this contract. Good morning, everyone.
Good morning.
Thank you for entertaining this request. Strata is our financial planning, analysis, and decision support software, which we usually on a daily basis, and it's a comprehensive package that really helps us analyze and report financial data on a daily basis and monthly basis. It helps us prepare the financials, et cetera. So we have the decision support module that went first a few years back. And to help leverage that, we also went to the financial reporting tool a year after. So we're kind of out of sync, and the decision support system is coming up due. And what we would like to do, what we're asking is that, number one, request for an exemption to bid because of the comprehensive nature and the integrated data that goes with it. It's very, very tied together to our core systems. And secondly, to help us align the two contracts, the decision support and the financial reporting, so then we can take it out for renewal next year, all in line. That's the request.
Yeah, some of the question I asked Sharon before the meeting was, because they were not the only vendor, right? Because you got EPSI, you got Affinity, Harris, and then you have
Yeah, and
Kaufman
actually,
Hall and all that stuff, so
we
I'm
are
just questioning.
pretty much, the industry is pretty much down to two main vendors, which is Strata. They purchased one of the other ones. There used to be three, so we're down to two, Strata being the dominant one in the market. And then there is, it's called Centellus now, but it used to
That's
be
Kaufman Hall.
Right.
And then the other one is DSS from Harris, bought the Vizian decision support software also as well. So there are actually three out there, but I think we're good with, because of all of the system interoperate together and all that stuff. So
Yeah.
Right, I think
Very,
that's the
very
piece
integrated.
that.
Yeah, I
that
think we
got
need to
it.
recognize that, and
Yep.
it's costly, and we would lose all the historical data if we move to another system, so. I will entertain motion to approve with the exemption. Ms. Dorothy? since it's
Okay.
Exemption to the bid.
I really thought I was giving this job up. Okay, I move that we approve the exemption to bid and the amendment for the software use agreement, okay?
Second.
Thank you.
Second by Dr. Hurd. Those in favor?
Aye.
Aye. Those opposed? On this one, I'm going to abstain from voting. The reason is that the company was purchased by Roper's Industry, and the Roper Industry, the CFO was my former the CEO is my former CFO when I was at MedAsset, so I'm going to recuse myself.
Okay.
Item D, thank you.
Thank you.
Mrs. Brown.
Good morning, everybody.
Good
Morning.
Thank you for allowing me to present three contracts to you today. Before I present the first two related to the T-Chat, I wanted to just give a brief overview for you all. You know, that was, we received significant grant dollars from the Senate Bill 11, and we received those monies and went live March of last year. And so I wanted to kind of catch you up with what we've been doing since March of last year, because I think it's something I know you'll be proud of. We are, with the work that Dr. Potter-Wiltz and Tanisha Kennard, my executive director over outpatient behavioral health, have been doing. We started March of last year, which is well behind others throughout the state that were also receiving Senate Bill 11 money. Not that we were behind, but the allocations. And so, at any rate, we currently now have almost 110,000 covered lives that we cover, which are strictly adolescents, well, pediatrics and adolescents, age 6 to 17. By the end of by this summer of 2022, we anticipate we're going to have close to 182,000 covered pediatrics and adolescents. And since we went live in March, meaning beginning to hire staff and contracts and roll things out, we've accomplished 435 televideo therapy with peds as well as adolescents. The largest volumes of requests for need are coming from the age group of 12 to 17. As we are getting more engaged with the school systems, our volumes are going up. December was the largest volume month we've had with our T-Chat program. We've also had 86 medication encounters, which these are kids that need more psychiatric intervention medication-wise than just a typical pediatrician would be able to provide. And thus far, we're in 8 ISDs. We're only one county short from being in all of the counties. That county, because I know somebody's going to ask. I've got it somewhere, but at any rate. And the focus, again, of the T-Chat program is to get services into counties where there's no behavioral health services, in particular rural areas. So you're looking at a little bit over 500 kids thus far that have had interventions by us, our team, that otherwise would probably not access behavioral health care. And so that's something for us, all of us, to be proud of, and JPS is playing an integral role in that. One thing that we're working on in 2022, besides more expansion in school districts, the state passed a mandate for all school districts to be trained in behavioral health and suicide prevention training. And so our program is going to be providing that training to all of the ISDs that we contract with in a train-the-trainer method so that it can continue even though we may not be there. I mean, you know, so it's a continuous training model. And so, and also we will continue to add ISD school districts. It's new for the school districts, and they're like, what do you want to do? What are you trying to do? And so, just to let you know, we've been recognized by the state for the large volumes of lives we're covering. We are number 3 in the state of Texas for lives covered, which is pretty cool. And we're still growing that. And we also have been recognized for having one of the lowest no-show rates for kids with their appointments, because we do them in the school. So they don't have to leave school, they don't have to be driven somewhere, it's happening right there. And so I just wanted to give you all a little update as to the progress we're making as I continue to bring these contracts to you so that you, and I'll, per Dr. Duncan's directive, will give updates periodically for the remainder of 2022. Any questions?
Yeah.
Well, yeah. Oh,
Several. Go ahead, Ralph. Go ahead.
The students that you see, who refers them?
So a teacher can refer them, a school counselor can refer them, the students can refer themselves, and parents of the students.
So, okay. So parents are aware when the school refers?
Yes, parents have to sign a consent for us to treat since they're an adolescent. Parents have been great about it because, like I said, a lot of these areas have had no access to behavioral health. Yes, sir.
So, since we're expanding this to several different counties, does the state provide some guidance relative to the boundaries that we have access to offer these services to? Or could somebody in, you know, Ector County call us and say, we'd like to have you on our staff?
So each district is assigned a cluster of counties.
Okay.
So we have our counties that we're assigned to. And
is that like basically the 9-county region?
Correct.
Of the SMA? Okay.
Is that the same region with the district?
I don't know.
You don't know? Okay.
I don't
That
think
would make
so.
way too much sense. That would make way too much sense.
Have received extra funding to add case managers this year because we're not only addressing their behavioral health, but we're addressing their social determinants that are barriers to them accessing mental health treatment.
So you said that, I may have heard that wrong, within our region and our allocated area, there's only one school district that is not signed up with us?
One county, and so there may be more, so we have at least one school district in every county we're covering.
Okay.
But there's one county that we have not yet been able to sign up a school district in that
And
county.
which county is that?
Yeah, I knew you were gonna ask me that.
You may know somebody, right?
Phone in there and my cheat sheet in there.
Roger knows all these people. We can have him give them a call.
Okay, I'll
curious.
find you after the finance committee, because it's in the ECR, I apologize.
All right, no problem.
On the, you said train the trainer and all that stuff. Is there a certification or recertification for that process down the road?
It is a state mandated program. I'm not sure if there's a certification process. There's just a required curriculum that schools must be trained in and adhered to in order for the prevention and early recognition of mental health in the schools.
Oh, I see. Is there a way we can track the outcome of the work for a long period of time to see if we can reduce crime, reduce suicide, reduce stuff like that.
Well, we're hopeful that the state, and just so you all know, right now, there aren't measurements of success from the state yet. They're in that governs this, and they're in the process of developing those. So I'm not sure yet what those measurements of success are, but we're kind of, because Tanisha is a data geek and everything else, we're kind of tracking our own stuff so that when it happens, we're ready.
Because I was wondering if that have any correlation with high graduate from less dropout or.
Oh, it certainly
higher.
would, absolutely. And I would think that since there are major medical universities attached with all of these and trainings, that there will be research studies done as a result of this.
So do you see us going nationwide and international with this project?
If they want to pay for it, maybe.
Yeah, don't tempt Zelia.
Zelia, how does the treatment work? Are we sending practitioners from here or contracting?
It's televideo.
All of it is?
Yes. And the young kids, they love it.
Yeah, it's right up their alley.
It is. They love it. And so it's been very accepted by them as well as the schools, because the schools are understanding, you do have an opportunity to hook the equipment up, and then there's a brief summary after the session with the counselor or the parents, if the parents,
So how does it work on the occasion that a practitioner feels that more interventions necessary?
We've made multiple referrals to local community mental health centers, inpatient psychiatric units, physicians, psychiatrists. So yes, we follow them throughout the course of the school year. And if their needs become greater than what can be managed in an outpatient setting, we certainly are intervening and getting them to the right level of care.
Cool. Thank you. That's great.
Are you at the point where we have to consider upgrading video, audio equipment, sound room type thing for that type of line of work?
We are not. Our IT team, David and his team, when COVID hit, we had 1 week to pivot, and we've got plenty of bandwidth. We've got great equipment. We don't have any issues with connectivity whatsoever, and our equipment is the best you can get. And the kids are loving it, and the staff are loving it. I mean, they really are making a difference.
Okay, thank you.
How many staff member counselors do you have?
We have about close to 20. And we have a physician, we've got 1 or 2 mid-levels, and then we also have MSW and LPCs that are providing the therapy.
Oh, good. Okay. And so for the 500, what are you anticipating by the end of the year?
Well, I would anticipate that we'll probably be maybe 1,500 by the end of this year. That would be reasonable, given only 5 months we've done 500, and that was just getting started. And now, the more we know, the more we're growing, and the more people are understanding, hey, this is a good thing.
Can we make a motion to approve this one and midway?
Yes, have you, actually, I know you gave your overview. Have you?
Yes, so I have 2 contracts to present. Sorry. Well, I just wanted y'all to understand what we were doing and the great things. Consider approval of an interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Prairie Valley Independent School District and Tarrant County Hospital District.
Entertaining motion.
Second.
Those in favor, say aye.
Aye.
Those opposed, same sign. Motion approved. Item E, please.
Ask the board to consider approval of an interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Midway Independent School District and Tarrant County Hospital District.
Entertaining motion to approve.
Second.
Those in favor, say aye.
Aye.
Those in, opposed? Same sign. Motion approved. Item F, Ms. Clark again.
Thank you. Asking the board to consider approval of a subscription agreement between Tritium Incorporated and Tarrant County Hospital District. The total estimated cost over a possible 5-year term with 3 years, 1 term with potential 2-year renewal would be $914,544. We have the $186,300 and the $60,000 for capital costs in our operational budget for FY22. So I'm pretty excited about this. Tritium is a platform that they have a proprietary algorithm, and so what will happen is patients will come into our outpatient clinics and they'll self-take various depression, anxiety, post-traumatic stress disorder type of assessment and tests, and then it routes automatically into Epic to the provider. And then when they come back every session, every couple of weeks or every month or whatever, they reassess, and we're able to track and measure their progress in treatment to know whether our interventions are actually working. Medical side of healthcare has had this. Behavioral health is coming into it. And so this really allows us to provide measurement-based care to our outpatient volume, our outpatients in our clinics, as well as our community health clinics, because they're our partners in crime. And so our patients will have iPads when they come in, and they'll get a QR code. They scan it on their phone and do it, or do it with the iPad in the clinic, take all those tests, and by the time they're called back, our providers will know where they're scoring in all of these various assessments. And depending on what the patient is presenting for, we can specialize an assessment just for that problem. And then it automatically feeds into Epic. And so this is also a regulatory requirement by Joint Commission and CMS that behavioral health has to have a way to measure care, measurement-based care. And so we actually put an RFP out for this, and we had 5 or 6 responses, and Tritium was the best with regards to ease of access in connecting with Epic, as well as the platform that it provided along with cost.
And these are rule-based and everything else that you can customize and configure internally?
I'm sorry, say that.
Are these rule-based so that you can internally configure with your team?
So we're able to configure with the Tritium anything we want it to do. Matter of fact, when our patients see these on the iPads, it's not going to say Tritium. It's going to say JPS Health. So it's going to be a single connection. But we are able to make changes within the program. Tritium is an excellent company to work with. They were great during the RFP process. So I don't see that being an issue. And we had IT involved from the beginning so that, I mean, you know, I want to make sure it really works with Epic.
So how long is implementation, and when do you think it's going to be fully functional?
Implementation is about 4.5 months.
Okay.
And so we anticipate if we get the signing that this is January. I'm going to say July just to be safe.
And they do have API into the Epic system. Right? Okay.
They do.
Entertaining motion.
Move approval.
Second.
Those in favor, say aye.
Aye.
Those opposed? Motion passed.
Okay.
Thank you,
Celia,
ma'am.
thank you for the report. That was very good.
You're welcome. Thank you. I
Okay.
appreciate you all supporting us and helping these young kids, because Lord knows
By
they
next year,
need it, especially today.
by next year, we're going to have a special committee just for you.
I don't know about that.
Item G, Mr. Mendenhall. Hi, David, how are you?
Hey, good, thank you, sir. As long as the extra committee is resilient and not me, I think that's a fantastic idea. So,
Surprised you only have 2 on here today.
yeah, I only have 2, and they moved me up in the agenda, so you guys aren't tired, so I'm a little concerned about this. So, the first one is it's a 2-part piece, one exception to bid and second for the contract. This is for our agreement with our AT&T vendor, which brings in all of our voice and many of our data circuits into JPS. And so we're going to be changing to some new technologies from the old PRI technology to new SIP trunking. SIP trunking allows us to be a lot more dynamic with what we do with calls in and out of here. So as we look at new technologies for the Access Resource Center and some of the other call centers that we have, it's going to be imperative that we are on a new technology and not the traditional things that are coming from AT&T. So there's an exemption to bid. There's also the contract here that I'm asking for your approval on. And you can also see in the write-up that there is a significant reduction in our cost overall on an annual basis to move to this new technology.
I would like to ask the committee to see if you guys need explanation on the PRI and SIP. We all good on that one?
No, I'm not. That was my question. I understand, I don't understand the jargon, so
Sure.
is that, just give it to me in layman term. What does that mean when you say?
So, and I always struggle with this, so I apologize with that. So basically what we're going to be moving is from old copper lines to fiber connections coming into our facilities. And when you read up on SIP, which is, Session Initiated Protocol, that's what it stands for. Basically, a lot of the documentation will tell you it's coming over the internet, right? Mm-hmm. So a lot of small businesses use SIP to be able to move calls in between people that might be virtual and so on and so forth. Big organizations have dedicated fiber coming into them from the providers. So it's going to be moving us from copper to fiber, which is great. But then also, as we develop data center concepts and so on and so forth, we can actually route that traffic now through different data centers, which will then allow us to be able to have call agents at home. We can have call agents anywhere to be able to answer calls. And without this new technology, we're really kind of landlocked to what's happening within the 4 walls of JPS.
Okay. AT&T moved me over to that. That's the one that my phone jack no longer work, right? So, just thought I'd tell you that.
I usually expect this from...
And my one concern with that is that internet was working, I could do all those, but my phone service went out, and it took them almost 45 minutes, an hour to get me back. It just was showing a busy signal on my, on my landline.
Yeah, that's the difference of unfortunately paying.
I was not.
Sometimes that's the difference of paying, unfortunately, paying $40 a month. We pay close to like $40,000 a month.
Okay.
And so we get a little bit better SLAs from AT&T when those types of things happen.
But I said that to make sure that when all things go down, we will have a way to communicate at this hospital.
Oh, absolutely,
Yeah.
absolutely. From that perspective, let me say it another way. From that perspective, we are at lesser risk with this technology than we are today. And my cohorts can tell you that our clinics become in jeopardy when the first, precipitation starts coming down somewhere in Tarrant County because copper lines get rusted, and the central organizations that are out there, their cards go out all the time. In fact, we had an issue this last fall at the Access Resource Center where phones, and we have hundreds of phones at the Access Resource Center, would just start freezing up. And it took AT&T, because of our old copper lines out there, almost 2 months to figure out it was their problem and not a phone system problem. Okay. So with this new technology, we'll be able to alleviate much of that.
All right. I just didn't want you to have my problem. Okay.
It makes it easier to move to it later on when we have a new building. Just to move the
absolutely, because we just throw the
line.
fiber to a new building. Thank you for bringing that up. And also understand that this is not riding on our internet circuits either, right? This is on a dedicated circuit that's brought in through AT&T.
Okay.
So do we need to have a backup from another?
We actually do. So AT&T is actually going to diverse the routes to our data centers and then coming into here, right, for that. And then we do have some backups, but In the past, those backups have not been able to handle the volume that comes in here. We answer close to, I think, 6,000 calls a day coming into JPS, and those backups have not been able to handle that volume. So we're constantly exploring what some of those other, whether it's Verizon, whether it's got all the different players that are out there. No one's been able to handle that level of volume coming into JPS. So we're still exploring those options.
All right. Entertain motion to approve.
Move approval for the exemption to bid and for the price schedule between AT&T and the hospital district.
Second.
Second by Dr. Hurd. Those in favor, say aye.
Aye.
Oppose? The second one, Mr. Mendenhall?
Thank you. The second contract is between us and Steris Instrument Management Services. Steris has been doing our scopes and surgical equipment for many years here at JPS. They've had a phenomenal relationship with us. This new contract, as well as the last one, kind of ups the amount of rebate we are allowed because of our run weights with our repairs that they do for all of our surgical instruments. This last year, we received about $141,000 in rebates because of the capitation plan that we have with them, which basically means our equipment was, we can go up to like 80% of this capitation plan, and anything below that, we get rebated on. And we stayed below that 80% all year long, and that meant we had about $141,000 rebate. We anticipate that this next year, but you just never know. But this year, is exactly what we're paying today for $746,000 annually.
Any question, discussion? If not, entertain motion to approve.
Move approval.
Second.
Dr. Hurd. Those in favor?
Aye.
Signify aye. Those opposed, none. Motion pass. Mr. Adam Lane. How are you, sir?
Thank you for the opportunity to present today. So I'm here to present an agreement between Whitting-Turner Contracting Company and Turner County Hospital District for $70,000. It's for remediation of the brickwork along the top of the 1400 JPOC building. Currently, we have some deterioration along the entire length of that parapet. We do need to remove some of the bricks, replace them, etc. And it is, we had 3 firms that presented. Whitting-Turner was the best value, and we have the right to terminate without cause.
And they are certified hub business also as well?
Whitting is not a certified hub, but they do have 8.68% hub participation in their contract.
Any discussion, any question for Adam? Yes, sir.
Mr. Chair, I just want to make it clear for the record, I'm not here as a voting member of either committee, just kind of here as a witness and to keep Trent Petty in mind. And Whiting-Turner is a client of mine, so I want to make it clear that I will not be voting, not abstaining, but not voting.
Okay. Thank you. Entertain motion.
Move approval.
Second.
Second by Reverend Emerson. Those in favor say aye.
Aye.
Those opposed? Motion passed. And please note with
Thank
Mr.
you very
Fisher.
much.
Thank you.
Have a good day.
Thank you.
Mr. Chung, how are you?
Good, how are you?
We sad to see you leave.
Sad to go. It's always tough to leave good people. It's always the hardest part, but appreciate your comments. So
I think we just update our HR policy. We don't release you, so how you
goes the quarterly, so maybe I'll get out. Just
Funny this morning on the operations call when we were just thanking Doug for the great service that he's provided us and his friendship and his partnership. I informed him that his position would remain open for 6 months, giving him time to see that he needed to come back to JPS. So.
I'm a former Houstonian, so I can be convincing if you need me.
Okay. That's good. I'll save your number. Well, thank you so much. This is a consideration of a third amendment to the Maxer agreement for comprehensive services here. It provides a 2-month extension. We're currently in an RFQ process that we feel like we'll be able to wrap up in the next 2 months. It's already been issued. It's kind of in the final negotiation stages. So this is just to continue services, and this is already budgeted in the FY22 budget. So.
I think the only question I have is, I guess two. One is that long enough for the extension? And number two is, if we need to cancellation, does this supersede the 30 or 60 days notice on top of that, or how?
So I do feel like it is long enough in the 60 days, just given where we're at with the RFQ process. I believe there is still a 60-day out, I think. I'll have to check on that one. But either way, I think given where we're at with the RFQ process, this 2-month extension will be coming back. But we'll be coming back to the board subsequent next month to continue on with this service. So,
let me ask you a different question.
Sure.
Let's say, if we assume that they may be the one we select, then we don't have to worry about it. But if they're not, does the transition 2 months for us to complete the RFQ and then transition and?
I think if it does take a dramatic left turn, I think is your question, we would then be coming back in subsequent months talking about transition services agreements and potentially reissuing RFQs related to this. So that would be a separate kind of action that we would need to then take on subsequent financial and board meetings in order, because even 2 months from now, the way I've done these in other organizations, given the scope of what Maxer provides, we'll certainly have to go on to a transition services agreement for a 12, 18-month period of time in order to transition to another. So either way, we're coming back.
Should they give us a preview of what the transition agreement would look like if we have to go down that path?
Oh, we can certainly ask. It's certainly something we can ask.
Because it's a lot easier to negotiate with a better price when they're still in the running. But not in the running, it's going to be costly for us, though.
Yeah, we can certainly ask for that.
Doug, was that original agreement a 3-year agreement?
The original agreement was a 3 with 2 1-year extensions.
So we're at the end of the second year on the 1 extension. Okay, thank you.
Okay. I guess, any other concern or question that you guys may have? Board member? No?
To approve.
I guess
Second.
motion to approve. Those in favor, signify aye.
Aye.
Those opposed? No. Motion approved. Thanks, John.
Thank you. Thank you. Appreciate it.
At this point, I'm going to turn over the remaining of the meeting to Mr. Petty.
Remainder of the evening, no. Quite that ambitious. As you all know, we continue to have our steering committee meetings. Dorothy, Roger, Steve, is that all? DT, Mr. Chairman. Continue to have those meetings. The last couple of meetings have focused really on how we go about determining the specific locations for the medical home. And you guys have seen the initial presentation that went through the zip code study that looked at the marketing analysis, looked at demographics, looked at the drive time, all those pieces of it. Derek and his crew have been working on that continually. We wanted to bring that back to you today. We are sort of circling in, I think, on locations, but I wanted Derek to give you guys an update on that today. And so that's the primary focus for the discussion. We will probably, over the next couple of meetings, see a significant number of RFPs and RFQs that will need to be released. And so you should expect those coming back to this committee to be able to move on to the full board approval. So, Derek?
Thank you, Dr. Duncan and Trent and board. So just wanted to give you an update on the current work that we're working on. And just to remind you, I think the real estate portion of that will go into a closed session. So there may be some questions, but we'll address that here in just a little bit. If I have control of this. Yeah, let's go to the next slide. So I wanted to give an update. And on the medical homes, we have, for all the right reasons, have focused on medical home number 1. But when we did that, we knew we were taking that a bit out of sequence. Typically, what we want to do is look at the entire ambulatory network, and that's what's represented on the map that you see in front of you. And the work that's being done right now takes in the whole ambulatory network and the rest of the medical homes. We've got, according to the Blue Ribbon Report, 2, 3, and 4, but those are coming up in the future, and we're looking at that very holistically, including number 1, but we're looking at what are all the factors that need to be factored in the entire ambulatory network. So that's what this map is representing, is we've got in the large red dots, those are actually what came out of the Citizens Blue Ribbon Report. One of the initiatives that Guidehouse has been going through is going back and look at that, validating and adding some new matrix into that to kind of validate those locations. So just overall, we've got more work to do. We'll be bringing those recommendations in that final report to you in the next couple of months. But just to emphasize that we did, for all the right reasons, focus on medical home 1, but we're looking at the entire ambulatory network that takes in all of existing clinics, takes in what the need is in the community. So that's what's coming up. On the next slide, I wanted to talk briefly about one of the particular areas that we have looked at. And it's interesting because it does fit in, again, with the Blue Ribbon Report and the Southeast Arlington area. It's interesting because that's a very dynamic area, and there have been a fair amount of changes since the Blue Ribbon Report to that entire area, with a lot of people moving to that area. So we're taking that into consideration, taking a careful look at this particular area of the Southeast Arlington, and wanted to make sure that we are looking at that area in its entirety, looking at the Southeast Medical Home, the existing Southeast Medical Home, looking at all the other services, and also just know that some of that area is hitting really close to the Dallas County line, and we brought that up in our last executive steering committee. So we're carefully analyzing that area to make sure that we meet the needs of the area, we take into consideration the services that are needed, but make sure we put it in the right location. So just wanted to let you know that this is one that we're spending a little extra time on right now to make sure that we get it right. But again, what you see circled, kind of an oval circle, is the area, and actually the box, the entirety, is what was focused on the Blue Ribbon Report. Reminder, the Blue Ribbon Report, you may see a star, you may see a dot on the map, but that is truly and represents an entire area that we're looking at. So that's what you see in that square box, is what was coming out of the Blue Ribbon Report. So again, we're taking a lot of attention in this particular area just because there's been a lot of new dynamics. And that's what I have to report on currently. There's a lot of other work that our team has been working on, but this is what we specifically wanted to hone in on. And like Trent mentioned, we'll focus on the real estate piece, I believe, here in just a little bit.
So yeah, we'll go to executive session and have that item when we get to executive session. We'll discuss that further. Secondly, I think one of the things we wanted to make sure that we did with our transition in the steering committee and trying to join finance and planning together is to not overlook the capital work that we're doing here in the hospital on a regular basis. So I've asked that we restore that item to the agenda to make sure that we have reports coming from Angie and company on all of our existing projects And I think that's where we are now, right? Are you doing that?
Angie's
Angie's here.
doing
Oh, come on in, Angie. Wait, come on in, Angie, come on. Sure.
We're looking at the location of the medical home. Are we doing an economic study also of that community?
Yes, sir. Yes, sir. There's many factors that we're looking at, but we are, one of the criteria that we look at is what's going on with the economy of the people that live in that area, what is their income level, what is their ability to drive to a location. There's a lot of detailed information that goes into that analysis.
Okay.
And those were in Blue Ribbon also, Ralph. We took all those same variables that were reviewed in the Blue Ribbon Committee, and Guidehouse actually added to those variables with what you're seeing now. So none of those have been excluded. All those variables that were originally included in Blue Ribbon are also areas that are looked at in terms of how this report's moving forward now.
Okay.
Any other questions for Derek?
I got a problem.
What's,
No, I'm through. I'll wait.
okay, okay. Any other questions for Derek? Okay. Hi, Angie.
Good morning.
Good morning.
Thank you all for taking the time to listen to my report this morning. So this report is on the planning, design, and construction ongoing capital. This is routine capital, not bond related. The first one that I wanted to talk about this morning is the OR Endo and OBOR refresh. That was a regulatory compliance project. If you're not in healthcare, it still is common sense that your ORs have to be pristine. So we want our floors to be perfectly smooth, no bumps, cuts, tears, nothing in them. So we redid all the floors with a stone hard product that's a poured in place product like the terrazzo that will last us a long time, and there's a great picture. The staff helped pick the colors on that. We also put up, really it's like armor, wall protection. Those are busy ORs, and things get bumped into the walls all the time, and that protects our walls. So if you look, we're about 99% complete. Most of the work in the room is complete, but while we're in there and we have the room shut down, we're replacing shelving or any little thing that's a maintenance item that we can do, we're getting in there and doing it. So that's the first one, and all of these, by the way, have been approved by Planning, Finance, and the full board. The chiller install and thermal storage decommissioning, that, if y'all remember, we added a 1,250-ton chiller, and if you've never seen a brand-new chiller, there it is. It was installed back on July 3rd. We do still have some work to do on our thermal storage decommissioning, but that chiller is up and running. So that project is still in progress, and you'll hear about it again at our next meeting where I do a quarterly report for you. The last one is the central plant structural repairs. And the reason I showed this particular picture, I thought it was important. I know some of y'all went down to the plant and saw the condition it was in. And thank y'all very much for approving the money to fix this.
Happy to get out of that tour alive.
Yes, you're right, Mr. Chair. You are right. But that is engineered structural support. So literally a structural engineer did that while we worked down there to correct all the deficiencies, that we keep everybody safe and we keep our equipment safe. If you look above, it's supporting the deck that's above you, but that is ongoing. We are continuing to work down there, and I know we showed a picture of it months ago, but there was some corroded electrical wire. Y'all remember the corrosion, and we really had hoped to clean those and not have to replace that, but we have discovered that we're going to be replacing that. So at the next report, I hope I'm able to say we've replaced that and we're winding down. So all of those are ongoing, and I will continue to report until they're finished. But do I have any questions this morning? Nope.
Good job, thank you.
Oh, you're welcome. Thank you all.
Come back and see us next time, too.
I will do it.
Thank you, ma'am. And next, we have our strategic plan. The other thing we talked about doing is beginning to make sure that we have, at least quarterly, strategic plan updates that show the progress of the strategic plan relative to all the different things that we're doing. So Lauren is here to walk us through that.
Good morning, thank you. So I'm here today to provide, as Mr. Chair said, an update on the implementation of the strategic plan that you all as board members approved in May. Before we jump into that first update, I did just want to provide kind of a high-level overview of what you as board members can expect moving forward throughout the remainder of the year in regards to strategic plan updates. As you're aware, you all received an FY22 board and committee binder or book from Chairwoman DeBose earlier in the month. In that book, there was a document titled the FY22 Board and Committee Meeting Year at a Glance Executive Summary. That is a mouthful. And so as part of that, we have worked very closely with Ms. DeBose over the last several weeks to begin to outline an overview of what items will become standing agenda items as well as ad hoc agenda items for both the full board and all of the committees. In addition to that, at the request of Chairwoman DeBose as well as the other committee chairs, we have taken a look at how we begin to report out our strategic plan work and other work throughout the organization through that infrastructure, consistent with the bylaws and consistent with what information should go and be presented at which committee. And so all of that information in detail can be found in that document that I just referenced. But what you can expect to see is that every month I will come before you, or quarterly, depending to Mr. Petty's point, how often we need to provide that. I will be coming before you with a high-level update. As part of that update, I will provide you an update on the outcomes or the KPIs that the groups have worked to assign. That again, I know Mr. Nguyen, we are all about tracking outcomes, not just the work that we're doing. And so part of that will be reporting out those KPIs that are reflected in the organizational goal scorecard that Dr. Duncan and I referenced at the HR committee meeting in December. In addition to that, I will start to bring with me executive champions who oversee our strategy implementation work groups, and they will start to give an update and a report out on both the work and outcomes of their strategic implementation work groups that are implementing the work that you as a board approved. I will say the majority of those updates will flow through the steering committee, the planning committee for the most part. However, there are going to be some of those updates that go through other committees. Just an example of that would be our culture of safety work and our high reliability work will flow through quality committee. Again, that's most appropriate given the purpose of that committee. And another example would be our diversity, equity, and inclusion work relative to our workforce, team members, and providers. You'll start to see those updates go through the human resources committee. But large in part, the majority of the strategy updates will come through planning. Any questions before I jump into the first update? Okay. Perfect. So with that said, I would like to give the first kind of official update on behalf of all the work across the organization that's going on. I'm just the voice of that today. This is a very heavy lift with multiple individuals and teams involved. So I do not take credit at all for this. This is definitely a team effort. The first thing I just wanted to remind us all, these two documents you're about to see on the screen are not new. They were in your board binder that you received from Chairwoman DeBose. But we do want to keep this in front of you. And again, to Chair Petty's point, we want to make sure that we're continuing to remember what the strategic plan was that was approved and how all the work we're doing across the organization ties back to that plan. So what you see on the screen in front of you is a one-pager. Dr. Duncan has actually set the expectation for the executive team. We should all be printing this one-pager, laminating this one-pager. It should be at our desk. It should be at our break room huddle board. It should be everywhere. We should all be very familiar with this one-pager. And it should be essentially the page we live by here at JPS. So I wanted you all to have that copy as well. On the next slide, again, since this is kind of the first update, I just wanted to take a minute or two to help you to understand how it is we are going about implementation of the plan internally. So, of course, we cannot do everything at one time. This was intended to be a multi-year plan, so we cannot devote resources to accomplish everything in year one. So we are having to take chunks at a time. And so you all, as board members, approved in the budget process several initiatives for implementation in FY22's budget budget year. And so what we have done, I am a big believer in collaboration. I am a big believer in interdisciplinary work and not having silos. And so we have developed an infrastructure that we actually tested through our DISRP work that was very successful, where we have executive champions that are partnering also with clinician champions to drive the implementation of these strategies. So this is essentially the slide we just looked at. This is a detailed version of that slide so you all can remember the actual initiatives and strategies that we talked about implementing. Each one of those yellow, red, and green boxes all have champions, executive champions assigned to them, and it is more than one. So in a lot of cases, 2, sometimes 3 executive champions where appropriate, depending on what the work entails and who might oversee that work throughout the network. Again, we also have physician representation or clinician representation on every one of these work groups, and every one of the work groups, again, is multidisciplinary. In a lot of cases, you have IT at the table, you have pharmacy or case management, whatever it may be, whoever the necessary parties are that need to be involved, behavioral health, absolutely, are at the table. So I just wanted you all to understand how this is being implemented. We didn't just say we were going to implement it and cross our fingers and hope it gets done. We do have an infrastructure in the background that is working. Most of these groups, I will say, meet biweekly or weekly. Some of them don't like me right now because the calendar invites that they see on their calendars tend to populate their calendars quite often, but they are working very hard, and those will be the future updates that you receive. So the other update that we wanted to provide, Derek, if you can go ahead and switch over to the scorecard, is a circle back from the conversation that Dr. Duncan and I had with you at the December HR committee meeting. So if you recall, as we presented the FY22 proposed AIP metrics to you all in December, we talked about how those metrics were simply a derivative or a subset. Oh, Derek, I think we switched it back over. There you go. Those 5 AIP measures that you all approved, and then those 3 LTIP measures were simply a subset or a derivative of an overarching organizational goal scorecard. I know there were a lot of questions that day about, what scorecard are you talking about? And so at your request, we wanted to bring this back before you so that you can see that scorecard. What you'll see on here, and this goes back to answer your point, Mr. Petty, in December, asking where are all those other measures that you're used to seeing tracked? They are all reflected through the scorecard. Again, the goal of this scorecard was to truly take all of the work across the organization, the strategic work, the operational work, the clinical work, financial work, and combine it into one overarching, if you will, balanced scorecard is kind of the industry term, balanced scorecard to track the pulse of the organization. So that's what this is intended to be. The sections that you see on the scorecard directly match that one pager that you just saw. So you see our True North, our patient section. This is the section that has all of our quality, patient safety, and patient experience measures. You see then, Derek, you can scroll down a little bit. Those next 3 sections are the strategic imperative work. So again, that ties directly back to the strategic imperative strategies that you all approved as a board around a culture of excellence, the care model development for the future, which is where you see that population management, the holistic care, JPS connection work, and then being at the forefront of shaping thriving, inclusive, healthy communities, which is large in part where our DE&I work is housed. And then the last 5 sections there, again, all of this should, hopefully you can see the visual tie we're trying to make so that it's very easy to connect the dots. But those last 5 sections are all the enabler work. So we talked about, remember in our strategic plan, that there are things that, more of your operational things that go on day to day that we have to continue to do in order for our strategy to be successful. And that's where you see the financial strength measures. That's where you see, of course, our employee engagement, team member, clinician engagement measures, IT, all of those things. One thing to note, we do have on here at your request a measure around philanthropic funding. I know that over time that measure will change as we get new leadership in that position. I know we're closing in on that, and we start to develop the vision and strategy for the foundation, but we felt very strongly hearing you all during the process last year, we at least needed to start somewhere with having some sort of foundation type metric on our organizational goal scorecard since it was a priority. So that is really what I wanted to provide you all today. As an update, again, you'll see the only other thing to note is I've tried to indicate which of these measures were the AIP measures you approved and which of these measures were the LTIP measures you approved, just so you can clearly identify how they were a subset of the overall scorecard.
Lauren, when you provide this in whatever increment we decide, are you planning on providing that card with the report?
Yes, sir. So when we come back forward, we will start to bring you the year-to-date results for all of these measures.
Okay.
The one thing also that I did want to say is keep in mind, large in part, a lot of these measures may stay the same year over year as we work to implement the plan, right? Because a lot of them are long-term KPIs. However, there will be a caveat that some of these may change year over year, depending specifically within those 3 strategic imperative sections of the scorecard as we take on new priorities for that year, right? Because we can't do everything at one time. Those measures may be changing more often because they really should be the KPIs that are tracking the outcomes of the strategies that are being implemented. But large in part, they will stay the same, and we'll just continue to adjust our performance targets and continue to increase them. But I did want to set the expectation that some measures may change year over year to truly reflect the outcomes of the work. I didn't want to come back next year and you go, oh, wait a second, these are new. So,
What do you think in frequency in terms of reporting back to us on this? What's your preference, quarterly or monthly or what?
I would say at a minimum every other month to provide. I would not like to go quarterly simply because I do think that, again of me, but there's a lot of great work happening with our work groups that I do think the board needs to hear about from our executive champions, specifically around the items that you asked us to work on and focus on this year. So I would like to ask for at least every other month. But I'm happy to talk offline both with,
Well, that's great. I was thinking quarterly might be too far also.
Okay.
The other thing is, for whatever reason, we weren't able to get the blue scorecard into the portal.
Okay, we'll make sure and get that.
We can make sure
Absolutely.
that's with it, because that's what people are going to focus on, is what are the numbers relative to the last
Absolutely.
term. And I think reporting is going to evolve with this in
Okay.
terms of how we can communicate with you about what those reports are. And the other thing I think we want to be conscious of is this can be perceived as pretty static in terms of what we agreed to at the beginning of the year, and now what we're doing relative to those agreements. There's a lot of opportunities that are coming up today.
Absolutely.
And there's opportunities that are going to be coming up tomorrow. And one of the things we need to be able to do is sort of introduce into this scorecard those strategic imperatives that are really just now emerging. Some of the stuff that you're working on right now, Karen, could be really important to include in this.
Yeah, so Lauren has not spoken to this, but there will be a retreat for the executives to, again, look at the strategic plan and, to your point, make those necessary changes based on what we're coming and seeing. And then she will move forward with the retreat for the board. So again, that this is more an iterative, but has a platform by which we're moving through this.
Great. Does this meet the board's expectations of what y'all were looking for in terms of strategic planning update?
I think it does, and I think that it gives us a way to say, here's what we are looking toward, but it also, to your point, is fluid enough for us to be able to add stuff to it as it come up, because it will fit into the strategy of where we're going. So I think on a one page, it does a good job to tie everything together. It helps the committees to be able to look at what they are going to be looking at. So I think it's a good job.
This is, to Dorothy's credit, Dorothy is one that has said, let's make sure we bring all this information to the board at the beginning of the year, but let's keep this in front of the board as we move forward. So Dorothy, thank you for your work and help on this, and Lauren, for you for putting all this together.
Mm-hmm.
We'll see you in no less than 2 months, right?
No less than 2 months. And to Dr. Duncan's point, we will circle back on dates for, it will not be big of a retreat, it'll be more of a workshop, but we will have strategy retreats, and I do want to set that expectation that will be yearly moving forward. So while we have our long-term, what we just went through this last cycle was our long-term planning, which set that document, 20-page document that I always refer to, which is a multi-year document. But to your point, Mr. Petty, every year we should be doing an annual cycle whereby we're assessing the marketplace, we're assessing the industry, we're assessing all the factors that are happening financially, et cetera, and making sure that it's still relevant, and that we agree as an executive team and ultimately a board what FY23's focuses are going to be, and then FY24. And then that will then drive metrics, et cetera, and report outs moving forward.
Any other questions for Lauren? Thank you very much.
Lauren, before you go, I know I sent it out as part of the CEO update to the board, but again, I wanted to remind you that Lauren has been promoted to VP over strategy, well-deserved, the great work that she's done in putting together this strategic plan and keeping it out in front. And also will serve as chief of staff, which I think all of you will have to say a prayer for her, having to overlook Dr. Duncan, but she's done amazing work. So thank you, Lauren.
Thank you
Well
all.
deserved. Congratulations, Lauren. And that concludes planning, Mr. Chairman.
We're going to go into, reconvene to executive session. According to the Texas Government Code, you guys want to take a 5-10 minute break or anything? Let's reconvene at 11:45. Thank you. I feel good. We're going to reconvene into open session at 1:01. And we have one outstanding approval for item 3A, request for approval for unbudgeted items that we discussed in executive session. I'm entertaining a motion to approve.
Move approval of the recommendation.
Second by Reverend. And all those in favor say aye.
Aye.
Oppose? Motion pass. And I don't think we have any other items for discussion. I'd like to thank everybody for putting up with me for my first meeting. And I failed to recognize to welcome our new CEO sitting right next to me. And we're looking forward to your guidance, and we're going to lean you on guidance and transforming this institution for the years to come. Thank you all.
Okay, thank you.
Appreciate it.